The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead.
Welcome to Project Independence and You.
Good morning and welcome to Project Independence and You Community Talk Radio on 88.1 FM and WCWP.org. I'm Rebecca Miller, your host today, of course, along with Otto Lohse. Good morning, Otto. Welcome.
Good morning, Rebecca. Always a pleasure to be here.
It's always great to have you. Also, of course, we have Kristina who is the radio show producer and also the director of Senior Citizen Affairs for the town of North Hempstead's Department of Services for the Aging Project Independence.
Wow.
She brings these radio shows together. Yeah, I get my breathing work out.
It was really good. I was impressed. It was like all one breath. Yeah, it was very impressive.
So Kristina, pulls these shows together and gets really good guests, just like the guest we have today. And it's a great topic as I sit here aching. So our guest today is Monica Richey, and Monica Richey is a nurse practitioner, a senior nurse practitioner for the Division of Rheumatology at Northwell Health. And we're going to be speaking to Monica today about arthritis treatment, what everyone should know. So first of all, thank you so much and welcome to Project Independence and You.
Thank you. Thank you for having me. Very happy to be here.
Well, we're happy to have you because we have a lot of questions. But before we get into all the questions, maybe we could just have a little bit of a background on you and how you kind of came to this area of specialty.
Sure. I've been working in rheumatology actually since 2005. I started as a per diem at the Division of Rheumatology there, and I was a registered nurse in the infusion unit. And from there, I grew up and to be a nurse practitioner. And so I started my training in rheumatology as a nurse practitioner around 2009. My passion has always been patient education because I think the more the patients know, the more likely they're to understand their treatment. Why do they have to do certain things and not other things? There's a lot of crazy information out there. So I think that if the more we educate, the more they know about it from correct sources, the better they are and the better they will feel.
Great, because I think you're right. There is confusion, the whole area of rheumatology, when someone should go to a rheumatologist or someone like you. What are the signs and the symptoms and the things that differentiate an ache from something that could be osteoarthritis. But I know for me, there's a lot of terms that kind of intermingle, and I'm curious, like osteoarthritis, osteopenia, arthritis, whatever rheumatological things. So if, and I know that as we get older, most of us will be facing something in this area. What is I don't know, maybe you can kind of explain the range or the differences between all these kinds of symptoms and ailments.
So, arthritis is a general term, right? It just means pain in the joints. And there is over 100 different types of arthritis. And that's where it gets the confusion. And that's why you always need to see a rheumatologist. They refer to us if anything hurts. Osteoarthritis is the most common. Everybody gets arthritis. It's everybody who is a mammal, including dolphins, get arthritis. It's, just loss of cartilage. Osteoarthritis, there's just loss of cartilage. And as we grow old, or if you're like an extreme athlete, you start to develop more and more loss of cartilage. We are born with the same amount of cartilage we die with. Our body doesn't know how to replace cartilage. It usually replaces by creating either calcium deposits, calcifications, and other things, but it can never replace the cartilage that we lost. So everybody across the board after age 30 or younger, if you are, an extreme athlete, will develop a form of osteoarthritis. And then there is osteoporosis and osteopenia, which sometimes get confused, but those are more related to the bone strength. Women over the age of 50, 60 start to develop some bone loss, but that has to do with hormones versus loss of cartilage. And then there is the more famous rheumatoid arthritis. And rheumatoid arthritis is more inflammatory, is when your immune system is actually causing the problem. It's attacking the joints, it's making holes in the little bones, and then people have a lot more joint pain, a lot more swelling. And then there's psoriatic arthritis, there's gout arthritis, there is very many different types. There's pseudo gout arthritis, so there's many different types of arthritis, and it's good to go to the rheumatologist and really know which kind of arthritis do you have.
You know, you've mentioned a few times, go to a rheumatologist, and I think where a lot of confusion comes in, at least on my end, which is pretty naive in this area, people wind up getting told to go to an orthopedic. They have joint pains and whatever. And I frankly, in all my years, have not heard anybody say they were going to a rheumatologist. They always wind up going to an orthopedic person.
Yes.
What's the, you know, how do you clear that track up?
So for the last few, I'll say 10 years, the tendency is that if you don't need surgery, if the orthopedic surgery cannot operate on you or inject you, he's going to send you to the rheumatologist, right? Because we do more of the clinical part, really the medical treatment of it, where the orthopedics is really more engaged in doing surgery. Obviously, if you have a shoulder injury, a knee injury, you're probably going to see first the orthopedics. And if the orthopedics say, you know, I don't think this is something that I can deal with, or if he sees any signs that this is a different kind of arthritis, different than osteoarthritis, which is all that he's going to look at it, or a fracture, then he's going to refer you to a rheumatologist. It's difficult to see a rheumatologist. Sometimes it can take 6 months. We are very busy, and to get a referral in sometimes takes a little while. So sometimes people do see the orthopedics first because they can see a lot more patients than we do. But if he thinks there is any complications, and the primary cares, you know, they usually send you to one or the other. But it depends on what your symptoms are.
So since a lot of these flare-ups happen as we get older, even though some of them can start younger, what are things that we can do to kind of prevent, or at least you know, push it off a little bit more? And also, what are the things that, you know, especially older people can do when they're in an active flare-up to kind of help?
Sure. So let's imagine that this is just osteoarthritis, not just, because osteoarthritis is the most common, and unfortunately, there is no real good treatment for osteoarthritis, right? We have over 15 medications for rheumatoid and psoriatic arthritis, but osteoarthritis really fall behind. And you know, so if this is osteoarthritis, then if you're having a flare up, obviously anti-inflammatories are the only drugs that we have for them. But that is tricky because it's not something that you should take it on a daily basis, and you should really take it in a minimal amount to help with the pain. Other things that you can do that is not medical is obviously range of motion exercises, icing, resting, talk to your doctor about supplements. There's a few that I recommend. Turmeric is very popular and very little side effects. So those are something that you can take constantly to help you prevent. But on a flare, I would say rest, ice, either Tylenol or a little bit of NSAID, never a lot of NSAIDs because of the risk of gastric bleeding and also renal complications with those medications. But usually if you keep yourself active and moving, and if anything is hurting, take it easy and just let your body kind of take over. And if doesn't resolve, then ask your primary care for further instructions, if they're to go to the physical therapy to help, or obviously to refer you to either an orthopedist or a rheumatologist if this flare-up lasts more than a couple of days.
You mentioned turmeric, and I looked at your PowerPoint presentation, and it says with black pepper. Are there different kinds of turmeric?
Yeah, so that's very confusing things with turmeric, right? First of all, people just tell me, I eat the powder. Don't eat the powder, because you're gonna have to eat a whole bowl of powder to have the same amount and concentration that you have in a pill. So you can eat as much turmeric as you want. You're not gonna get the concentration there is in the pill. And they usually recommend to be alongside with black pepper because the two together have a more of an anti-inflammatory effect. Sometimes
I'm sorry, what was that? With what?
the two together have more of an anti-inflammatory effect.
Okay, so there are like pills you buy that are turmeric with
Yeah.
black pepper?
The usual dose is about 1,000 milligrams. Sometimes they come in 500 milligrams. Sometimes they come in as 1,000 milligrams. Sometimes they come in with ginger, which is fine too. It's not a big deal. But if turmeric alone has anti-inflammatory properties, but combined with black pepper is a lot better.
You know, when you do the diagnosis, I'm pretty lucky. I haven't had the problem, but my mother, who's no longer here, clearly, wound up with 2 knee replacements, 2 hip replacements, and her hands were always very bent. And would that fall into the rheumatoid arthritis category?
It's I mean, it's difficult to say. So the classical picture of the rheumatoid arthritis is the deformed hand. So in the old days, before we had biologics, we had so many medications now. So the hands will go to the side, right? The fingers will be twisted, they will be turned in. Patients usually could not extend their fingers. There will be a lot of non, like you wouldn't be able to see the person's wrist because it'll be very swollen, a lot of inflammation there. But osteoarthritis also can cause a lot of deformities in the hands as well, right? When we talk about knobby hands, like my grandmother had knobby hands, so I'm waiting for mine to start. So where you have ore on the little tip of the fingers that they start to get a little knobby and they get painful, particularly when that little knobby is growing, is because it's just forming bone where bone shouldn't be. But usually that's what we do in rheumatology, right? We'll figure out what kind of arthritis, x-rays, blood work, depending if we think that this is an inflammatory arthritis versus just osteoarthritis. But usually if they have that many joint replacements, it kind of like makes me think that she probably had rheumatoid arthritis, but it was never properly treated or diagnosed.
Right, I would say I never heard the word, let's put it that way. So,
Yeah,
she
in the
always
old days,
wound
they
up
all
with
call it rheumatism, right? It was all
yeah,
rheumatism. Yeah,
arthritis. You have
exactly. Yeah,
arthritis? Oh, yeah, everybody gets arthritis. Uh, I
yeah.
think what I've learned from preparing for this is arthritis is kind of like the word cancer or dementia, or it's an overview of lots
Right.
of different things that go on below that.
That is exactly correct. Our arthritis is just a big umbrella, and a lot of things fall underneath that umbrella. It's, as I said, there's over 100 different types of arthritis, and you need to figure it out which one is yours.
Now,
When people wind up with like bent over quite a bit, is that sometimes typically a sign of rheumatoid arthritis?
So the bend over, there's 2 things that can cause that, right? If you have scoliosis in the spine, and as we grow old, we'll lose a lot of the core muscles that support our spine, so we tend to get more bent over. Women with osteoporosis who had vertebral fracture can also get the little hunchback because they're losing space between the vertebrae because of osteoporosis, not because of osteoarthritis. And overall, if people have a lot of like back issues with disc issues where the disc starts to get small, you also start to shrink a little bit and you got a little bit of the curve. So there's many causes for that. It's difficult to say if it's one or another, but those 3 is the ones that come to mind. So osteoporosis, scoliosis, and obviously, just losing a lot of disc space in the spine.
You mentioned earlier about patient education, and we've talked about it on here quite often, that people have to understand that the doctor's not a wizard, and that the more input you can give to the doctor, about where the joints hurt or this hurts or whatever hurts, whatever symptoms you have, because I've looked at your material and the diagnosing of arthritis seems to be beyond the scope of it takes a long time to figure it all out.
Sure. Yeah. So the history is our main component in every visit that we have. We try to get as much as information, right? Where is the joint? When did the joint pain started? Do you have stiffness? Stiffness is a very classical symptoms that we always asking the patients, like, do you get stiff, when you get up in the morning? Can you get up and go? Or do you have to kind of warm up your joints and then be able to get out of bed? If you sit for too long, can you just get up and go? Because stiffness that lasts more than 15 minutes units is usually related to more inflammation versus mechanic, right? If it's osteoarthritis, usually the patient's like, yeah, I get up, I give it a couple of steps, I'm stiff, and then I'm able to go. Then I know this is more osteoarthritis related. But to say, yeah, it takes me like at least half an hour in the morning to be able to move. I have to get in a warm shower to be able to move. Then that leads me more to believe that this is more of an inflammatory rheumatoid arthritis like. And then we have to start the proper workup. And that can take a couple of weeks until we can get all the information, for sure.
You know, some medications, cholesterol medications, I had this experience myself. I'm an active person. I do yoga and all that kind of stuff. And about 4 years ago, I was put on a cholesterol medicine for generic. I have a high LDL, it just for whatever reason. So it worked tremendously. The cholesterol medicine brought it down. My subsequent blood work after it was always really good. But I started getting pains in my joints, aches, and it really wasn't, it was not fun. And I didn't really relate it to that until I went back to the doctor and I did some research on Dr. Google. And Dr. Google did mention that that is one of the side effects. So when I went back, I'm now taking it every other day. Unfortunately, my LDLs did go up, but it's not as bad, and my ratio's great, even though they don't think ratios matter anymore. But I'm not a medical person, so I probably shouldn't say that. You listen to your cardiologist, whatever they say. But and it stopped.
I had the exact same experience.
It stopped
with statins.
Yeah, it was Crestor or whatever that.
Yeah, it's classical. We always get those referrals too for patients who have
Right.
either muscle spasm that they cannot explain, can give you horrible muscle spasms and a lot of muscle aches. I cannot walk anymore. My legs feel heavy. And then you go over the list of medication. That's a statin. And then, if we pull it out and you tell me, oh, I'm good, then, either you can take it every other day or they have to switch to a different type of, which can usually help. But yeah, that is definitely a classic side effects of statin. So you always need to put together what medications you're taking and when your symptoms started, which is also what we ask.
Great. Good to know. We actually have to take a quick break. You're listening to Project Independence in You, Community Talk Radio on 88.1 FM and WCWP.org. We'll be right back with our guest, Monica Richey, who's a nurse practitioner, and we're talking all about arthritis and what everybody should know. We'll be right back.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
And welcome back to Project Independence in You, Community Talk Radio on 88.1 FM and WCWP.org. I'm Rebecca Miller, along with Kristina Liu and Otto Lohse, also Dan Cox. We are speaking with our guest today, Monica Richey, who's a senior nurse practitioner for the Division of Rheumatology at Northwell Health. And just before break, we were talking about some people have side effects from statins or other kinds of medication. So if somebody comes to you with those symptoms, I assume that there's also blood work that you can do. And I think, like you were saying, that it's so hard to get into a rheumatologist. Is the blood work that you would do or recommend to do something that your primary could do to help diagnose before you actually get to a rheumatologist, and kind of to determine also if it is a side effect from a medication or if it is something that is actually going on that's diagnosable?
Sure. I mean, some primary cares will. The biggest problem that sometimes we encounter is that they do either a partial blood work or they do the wrong blood work. and then people get in a panic because they can, Dr. Google, as you mentioned, you go there with your blood work and it can tell you have some crazy, very rare diseases that we treat.
Right.
So, and then, it takes forever to get into rheumatology and the people is in a panic. But definitely if you're having the muscle pain, all your primary care needs to do is, stop the statin or do a muscle enzyme panel. And also if he thinks his rheumatoid arthritis, there's two very simple labs that they can absolutely order, which is the rheumatoid factor, which is the oldest one, and the anti-CCP. Those are really the diagnostics for rheumatoid arthritis.
Right.
That is the primary care usually doesn't know what to do with those blood works. And then, as I said, sometimes they do it and then, it's an urgent referral if it's positive. But sometimes because arthritis is so tricky, some people have rheumatoid arthritis without having the blood work for it. And then you have to really listen to the history and really do x-rays and some further blood work to get to the bottom of it, particularly in the elderly, because your immune system slows down. So we don't see as many positive blood work as we'll see in a younger person. It's just the way your body works. But definitely if he thinks is anything, I would recommend the rheumatoid factor, anti-CCP. If it's more muscle wakes, it's really the muscle enzymes, and then take a look at the medications. And it's interesting. Sometimes patients get there and it's like, oh, I'm having all this muscle pain, and sometimes takes a little bit to correlate because they take so many medications, and sometimes they start 2 or 3 at the same time, since it's difficult sometimes to take it apart. But we always go over everything. And I really appreciate when patients either bring me a list of all the medications and supplements too that they're taking. Supplements count for a lot. Or bring in a list or all the medications. Sometimes it's as simple as getting through that list and figuring out what's going on.
Well, Monica, you would love Otto because he is a list man. He has lists of everything. He goes to the doctor, and we at Project Independence, we do encourage that with people. We always have medication management programs, and it's important not just when a medication changes to a different medication, but also an up or lowering a medication, to just always kind of keep track of that. Another thing that you have, in some of the information you sent us, and I'm always very curious about, is fibromyalgia. I know people that have it, and some people kind of, I'm going to say poo-poo it, but say, oh, it's really just something when the doctors can't figure out what's going on. Are there more clear tests today that can lead to it? Because I have friends that have it and they suffer. I mean, there's no psychosomatic. I mean, these are people that are in, that are suffering.
Mm-hmm. No, it's a real disease. It's not something that we make it up if we don't know what's going on. That is incorrect information. The way it works, it's a diagnosis of exclusions. If you come in and you're having a lot of pain in your fibromyalgia, you know exactly what to look for, right? But you have to do the full workup. You have to rule out everything else before you can say, okay, I think this is fibromyalgia, right? Because there is no specific test for fibromyalgia, unfortunately. To this day, they haven't found anything that I can say I can do this blood test and tell you for sure that you have fibromyalgia. There's a lot of research going on, but so far we don't have anything. So if you go to a rheumatologist, he's going to do a panel of blood work on you just to figure it out if this is something else. And then you have a criteria that we use, and it's not just pain, it's consistent pain. It's a pain that doesn't go away. It doesn't go away when you're sleeping, doesn't go away when you're waking up. They have very high sensitive the threshold for pain for them is very low. And what's happening is, what we know about fibromyalgia is that for some reason, your brain keeps a pain gate, and, it goes up and down depending, you bump your little toe on a corner, you have a lot of pain, you just, bump yourself and it's not as much pain, but the brain regulates pain. In fibromyalgia, for some reason, gates of pain are widely open. And so any small amount of like touching causes pain. They have trouble sleeping because of pain. So the medications that we use for fibromyalgia are different because what we're trying to do is close that pain gate, right? Because we have to decrease the amount of pain that patient is feeling. Why does it happen? We still don't know. We know that depression and anxiety sometimes are associated. Well, we don't know what came first, the chicken or the egg, because I don't know if that person is depressed and anxiety because she's in pain, or it's something that triggered it before. But our treatment, it's a real disease.
One of the symptoms of that, what I read, is that you get tingling in your feet. Now, I know people who have that, such as my wife, and they called it neuropathy.
Yes.
Now, is neuropathy a form of that, or?
No, it's just that there is different kinds of neuropathy, and people with fibromyalgia sometimes can have neuropathy, small fiber neuropathy. There is small fiber neuropathy, large fiber neuropathy, diabetic neuropathy. There is a million. It's like neuropathy is like arthritis, right? You have another million things. And people with fibromyalgia, sometimes they will say, I feel numbness and tingling, and they will have some form of neuropathy. But having neuropathy doesn't immediately give you fibromyalgia. And usually the rheumatologist is the one that treats the fibromyalgia patients, because the primary care wouldn't know. The pain management sometimes don't even treat them. It really falls more into rheumatology. And, we usually recommend mental health, pain management, lifestyle changes for those patients, actually lifestyle change for all patients with arthritis or any kind of pain. Your diet is super important, right? We are what we eat. And if you eat healthy, if you decrease a lot of junk food, inflammation goes down, and we know that the pain levels go down as well. So lifestyle changes for everybody is important.
And stay hydrated.
Absolutely. People don't understand how much water they don't drink in a day. And, it's like, maybe a glass, maybe two, that's not enough. But diet counts for a lot. So.
You mentioned the magic words pain management a number of times, and I've heard enough, and lucky again, I haven't had too much of it. But pain management is far from an exact science. And what I'm hearing is it's even more complicated with arthritis. Is that so? I mean, are they certain pain management methods for different forms of arthritis?
Sure. I mean, for people who have, for example, disc disease or herniated disc or any kind of spine, then it falls more into the pain management, because they are the ones who do the epidurals or other treatments to decrease the pain, right? They do the nerve blocks. So the pain management really more focus on that particular kind of pain, which is more the spine pain. We sometimes combine with them, just, if patients need narcotics, pain management is in hand, and they usually manage that. So we have like some separate like fields. Pain managers more really focus on like chronic pain that we cannot, as rheumatologists, manage it.
Not picking on any doctors. I know it's difficult, all right. But many times I've seen the experience and have the experience of the surgery goes well and the knee is working fine and it's all hunky-dory. But doctor, I have pain. Well, as far as that doctor's mentality goes, the surgery was a success, all right. But the patient is now living with pain, and there's like a whole gap there that takes place. Like, I'm trying to fix the pain. What do I do?
Yeah. So yeah, surgeons will be surgeons. So they're focused on the surgery. And as I said, that's why orthopedics just do surgery, and everything else they refer to either rheumatology or pain management, right? Because they don't do the clinical part of it. So if you
Some try to, though.
Sure. Some old orthopedics still do that. They would do send you for physical therapy, anti-inflammatories, to try to see reducing pain. If they refer you to either the pain management or the rheumatologist, they will try to figure out first, where is the pain coming from, right? Because it's, you had surgery, and you can have, anything that is complicated, nerve damage, healing issues, anything that may be causing your pain. And then we have to figure out what's going to be the best treatment. Do I need to send you for extra physical therapy? Is this like more of a muscle weakness issue versus this is more of a nerve issue? And then I have to send you to pain management because they have to do a nerve block to stop the pain. But there is several different treatment options for people in chronic pain. It's just a matter of really finding and getting plugged in with the right provider.
You know, Otto, you brought up kind of an interesting point, because I think we need to understand, the expectations of a surgery, like what you were explaining, realistic expectations with the doctor. If he's a surgeon and he says, well, this is what my job is, but the long-term expectations may be that you'll still be in pain, so that you kind of have an understanding. But there's just something I was thinking in my head, that's a question that we should ask our doctors when we are having a procedure, and that maybe they're not going to be doing the follow-up care. What are the realistic expectations of recovery? And will I be pain-free? So maybe if the doctor kind of explains, look, this is going to repair, you're going to be able to walk, you're going to be able to bend your knee, you're going to be able to get around, but it may not remove all the pain, but it's going to help your mobility. Like it sounds like maybe there wasn't an explanation. So I think we have to ask those questions, and that's something that we should also focus on with our advisory too, is to ask the doctor, especially if you're having a procedure, what are the realistic expectations of recovery? And will I experience pain even if the surgery is a success? So, I mean, I don't know, that was kind of what I was thinking, because I kind of think I know what you're talking about.
And
with that procedure.
That is the correct thing, because if you going for a hip replacement, a knee replacement, a shoulder surgery, right? It's and everybody expects it to be pain-free. Like, okay, I'm getting rid of my arthritis and I'm going to be pain-free, but that is not always the case, right? Particularly if you wait a long time to have surgery, there is damage, there is muscle weakness that goes along what you having arthritis. It's not just the joint that gets affected, it's everything around that joint. So sometimes people have trouble because they have to do a lot more physical therapy to regain movement and to decrease pain. So it's always a good thing to ask your surgeons, like, what is the expectations? Am I going to be pain-free? Am I going to, how long is my recovery? It's not just simply 2 weeks and you're good. Like shoulder surgery is at least 6 months to a year recovery. Knee surgery is anywhere from 3 to 6 months, and you're going to have a swollen knee for at least 6 months. So you need to really ask those questions before you go into surgery. Absolutely.
Well, and I also think that a lot of that comes down to people, like a lot of things you mentioned about what you can do. One of them was some sort of exercise, physical therapy, whatever. Not everybody is cranked the same way in terms of that. Some people really want nothing to do with that subject, and some,
Right.
And I think maybe what has to happen is a real forceful point that you must do this or you're going to have more problems than somebody who doesn't do it. And I think maybe they have to take the gloves off and not make it so easy. You're going to have to do some physical therapy. No, you're going to have to do some real physical therapy.
Yeah, and my patients think sometimes I'm crazy because they're saying, my knee hurts. I'm like, you need to exercise. You need to move that knee. The less you move, the worse this is going to get, because then the muscles are going to atrophy, and then you're going to have balance issues. So there is your body is a full working machine. Something is off. If your one knee is off, the other knee is going to suffer because you're going to put weight on that knee, and you may end up with 2 knee replacements instead of 1. So everything is really well balanced, and you do need to do your due diligence. Exercise, it's important. Activity is important. Just sitting in the couch, and I think it's cute. My patients like, I do that little bicycle in the couch. Like, that doesn't count, and that is good, but that is not really enough exercise.
My point really is that I think that it can't come from a family member, because that usually causes problems, right? So the doctor has to really, really lay it on about the fact that, this is critical. You must do this or you're going to have a problem. Like you said, Rebecca, about expectations.
It's the reverse. I
You
just wrote
soften the
down, it's the opposite.
expectations. Yeah, you soften the expectations. Maybe the doctor doesn't want to scare the person off about doing the surgery. But the reality is, if you don't set the stage with the real expectations, then they're going to have, like we talk, pain and ongoing. It's not a magic bullet. It doesn't just fix
Right.
things.
So maybe it's before the procedure.
That's what I'm saying.
You
Before, set the
start work, you
stage.
start an exercise so the doctor can then see. Because I know I had a friend who had bariatric surgery. She for weight loss, and she had to lose a certain amount of weight and go and prove and have proof that, I mean, she had to have like a lot of testing. They do a psychological test and all that. But she had to actually prove to the doctor that she had a little bit of weight loss, that she was going to the gym, and they wouldn't do anything until that. But we actually have to take a quick break. You're listening to Project Independence in You, Community Talk Radio on 88.1 FM and WCWP.org. We'll be back after a quick break.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing. And find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
And welcome back to Project Independence in You, Community Talk Radio on 88.1 FM and WCWP.org. I'm Rebecca Miller, along with Otto Lohse, Kristina Liu, and Dan Cox. And we're speaking to our wonderful guest, Monica Richey, who is a senior nurse practitioner for the Division of Rheumatology at Northwell Health, and just talking about all kinds of arthritic-related issues and questions. Something else that you write a lot about, and I think you had you specialized in, is the diagnosis of lupus. And I know, I mean, that's a really serious diagnosis. And is that also a diagnosis that's a rule out, or are there specific tests for that? And what exactly is lupus?
So that is a very specific diagnosis. It's a very rare disease. It usually affects women between the ages, I'll say 15 to 45, sometimes younger, and rarely over the age of 45. We have a few patients there. It is an autoimmune disease, and one of the really more serious autoimmune disease, because it can affect any parts of the body. And usually is more serious in people of Latin, Hispanics, Asians, and African Americans. They usually have more serious, more very severe disease. There are specific blood works for lupus, so you definitely need to see a rheumatology to get the accurate, to do the proper, there's over 10 different labs that we do to properly diagnose lupus. But that is your immune system that is attacking every different part of your body. It can attack the brain, almost times loves the kidney, so people can go into kidney failure. It can cause a lot of inflammation in the heart as well. And sometimes it just shows up as rheumatoid arthritis. People have joint pain, fatigue, fever. So it's a very serious disease. And it is a clear-cut diagnosis when you have the blood work for it.
I don't think either one of them are any good, osteoarthritis or rheumatoid, but it sounds like rheumatoid, I've learned a little bit during this whole preparation, is more difficult and more serious than the other, because of the immune system being involved, which you have no control over. It just kind of does what it wants. Yeah.
And rheumatoid arthritis usually happens over the age of 50. So it's different than lupus, where it usually targets more young people, where rheumatoid arthritis usually although there is young people with rheumatoid arthritis. And this, again, is your immune system that decides that instead of attacking viruses and bacteria, your joints are a better target. Like lupus, rheumatoid arthritis can attack other organs as well. Heart disease is very common with people in rheumatoid arthritis that are not treated, lungs, eyes, but it doesn't usually affect the kidneys or the brain. So each disease in rheumatology has its favorite organs that, likes to go and cause havoc. Lupus is definitely the most complex of them all. And rheumatoid arthritis, it affects about 2% of the US population. So below osteoarthritis and below gout, you have rheumatoid arthritis. So I'll say that that's a third one in amounts of it. But it's the one that we have the most medications. Since the year 2000, biologics came in, and you probably see the commercials, adalimumab, Humira, etanercept, Embro, Gelzan, whatever is out there. I'm not quite sure, but there's a lot of commercials out there. They really changed the game where you stop seeing the deformities. It really controls the disease. Only rheumatologists can order those medications. So your primary care wouldn't even know how to wrap that one up. Those are very specialty medications, but we have a lot more treatment for rheumatoid arthritis, even though it's much rarer than osteoarthritis.
But it sounds like a problem in the fact that you can't get to a rheumatologist for 6 months. So now you have to count on your primary doctor probably to manage your rheumatoid arthritis.
And
Unless
that's
there's
a problem.
yeah.
And usually we sometimes get direct referrals, right? The primary care will pick up the phone and call our practice and say, hey, I have this patient, it needs to be seen. And, we have like this waiting list that we always like, hey, can you add a patient here or add a patient there? And we try as much as we can to get people in fast. But I would say it would be like, unless the doctor is really calling us to get a direct referral, it would take you 6 months to get. With the doctor referral, it's probably a couple of weeks. So if your primary care doesn't know where to call, it's a problem.
So it sounds like if a young person wants to go into the medical field, they ought to look at being a rheumatologist.
Please, we need rheumatologists. There is a certain, for sure, shortage of rheumatologists right
Is
now.
there like any kind of backdoor effort, if you will, to try to encourage people
like skip medical school and go right? No, nothing like that.
No.
You have to go to become a rheumatologist. You do your residency, and then you go to a fellowship, which is usually 3 years, and then become a full-fledged rheumatologist.
That's good to Monica. So I have a question. I mean, this autoimmune. So autoimmune is like this word that just covers so many different things, because every time you hear allergies are autoimmune and thyroid disease and there's so many different things that are autoimmune. Is basically everything. Like the label of autoimmune, it's an autoimmune disease if it's lupus, it's an autoimmune disease if it's allergies. It's does that then, once you have an autoimmune kind of diagnosis, does that mean that you're susceptible to all these other things, or is it just specific to certain conditions?
No, so what we know these days about autoimmune is that it's a 3-prong, right? You first need a certain genetic predisposition, and it's over 100 genes that are involved in development of an autoimmune disease. And then sex matters, because women are more prone to autoimmune disease, because we know the estrogen facilitates the creations of autoantibodies, where testosterone kind of not really. It makes it very difficult. So women have a lot more autoimmune disease than men. And then there is a trigger, and that trigger could be anything. It could be a pregnancy for women, it can be surgery, it can be an infection, it can be stress, it can be many things, right? So we know that you need those 3. It's like a perfect storm coming together. So if you have those 2 and you have a trigger, you're going to develop an autoimmune disease. The tricky is once your immune system is off, anything can happen. So some people can accumulate autoimmune diseases. They can start with the thyroid, and then they can develop rheumatoid arthritis, and then they can develop multiple sclerosis. So as you said, autoimmune arthritis is all a big umbrella, right?
Right.
So autoimmune includes multiple different diseases, and it can affect any part of the body. But if you have one, you can definitely be in the lookout, because you can definitely develop a second one.
So
So
the
something
immune
like,
system is like this mysterious thing that we all have that,
right.
frankly, I don't think too many people out of the medical field really know what the heck that is. You know, your my immune system is weak. Well, what does that mean? I mean, I have no idea. What is your immune system? You know?
Yeah, so your immune system has many different functions. Or people think that it's just there killing bacteria and things like that, but it regulates a lot of other functions, right? If your cell die, your immune system is the one that goes and clean up all that cellular debris. If there is a fight between your bacteria and your immune system is the one that is clearing all that out. It's involved in cholesterol formation, right? So there is many different functions, and truth be told, we don't know everything that we need to know about autoimmune disease. We know that the cells communicate with each other very much. There is different, what we call a cytokines. When one cell wants to send a message to another cell, it's kind of like the Facebook of cells, and they just, put things out in the blood work to communicate with other cells. It's very effective when it works properly. But if anything goes wrong, if one cell decides to do the wrong thing, you can throw the whole immune system out.
Is there anything you can do to take care of your immune system?
Yes, lifestyle, it's important. Diet is important, right? We can avoid stress. We live in a stressful world. This whole thing, avoid stress, is impossible. But I think that if you can at least.
Thank you for saying that, because I
Yeah,
love when the
right.
doctor says,
Absolutely.
do you have stress? It's like, yeah. Well,
do you
avoid it. It's like, okay.
You cannot. This is just not possible. And then, you can control what you can control. So your diet is important, right? If you have any autoimmune disease, I'm going to talk to you about diet. It's a very hard diet to follow. You don't have to follow to the law unless you really want to, but it's like gluten-free, dairy-free, red meat-free. So it's a lot of free things that I know, like what? No
So
beef,
what's
no
left is
bread.
just
I'm
those.
like, I know it's difficult, right? But and then exercises. Everybody needs junk food every once in a while. You just don't need to eat it every day. You don't need to drink soda every day. So there's things that you can control. So I would say that the two more important things, if you want to avoid an autoimmune disease, which is not always possible, or if you have one and you want to help control it, diet and exercise are number one.
That's it, Otto. There you go.
I got it.
That's all we need to know, right?
I think there's some genetics involved too, personally.
Absolutely.
But
100%.
like I have the good fortune of having a few aunts who made it to 100. I think that's in my favor, but that doesn't guarantee anything.
No, and you can't just test it, genetically for autoimmune disease. Some have a marker that we can test for it, but it doesn't really matter, because you may have or you may not have it, even though you have or don't have the marker. So it's complicated, and that's why you need us, the rheumatologist, to interpret them. But yeah, your genetics, like as I said, my grandmother had osteoarthritis. I'm waiting for mine to start. So just have to look at your mom's hand, your grandmother's hand, and you're kind of gonna know which way it's gonna go.
My mother had it very bad. My father didn't. So luckily, I think I got that end of the deal.
You got it.
But my mother, I mean, I remember when I was a little kid, even it started when she was pretty young.
That
She
is
wound up
definitely
with
a rheumatoid.
all the joints being replaced, and her hands were always, like I said earlier, very bent, and but she never complained. She was a type that just didn't complain. I'm sure she had a lot of pain we didn't know about.
And there was not a lot of treatment until the early 1950s. We had prednisone that came in the market. Later in the 1970s, we had some medication. At some point, there was gold injections that we used to treat rheumatoid arthritis. So, we've been through the gamma, but there was never per se, I would say, really good treatment like we have since the early 2000s.
But the need to get to a rheumatologist is very important, unfortunately,
Yes.
which is a difficult thing to do.
Monica, I have to say, you are an excellent educator. I have learned so much today. You know, your explanations are terrific and, you know, they make sense. Is there, I mean, I know it takes 6 months to get to see you, but is there a way that our listeners, through listening to you, could make an appointment, or what's the best way for them to get in touch with you?
So, our main office is in Great Neck. Our phone number is 516-708-2550. Sometimes it gets tricky. It's not the easiest phone number to get around. I can post my email because I can also help make the appointment. My email, I will put it in the chat, and it's Richey, so MRICHEY1 at northwell.edu. And then I can help you guys get it in much faster than you would if you just have to call the office, say, hey, I think I need to see a rheumatologist. And if you call and give us a specific, you know, you can just say, I'm in pain. That would take you 6 months to get in. I have a swollen knee, you know, I can move my wrist. Give us a specific. That usually facilitates you guys getting in much quicker than if you just call, I have pain.
Excellent. So if anybody, any of our listeners want to get in touch with Monica and they didn't get the phone number, you can always call us at 516-869-6311, which is the 311 call center, and just get in touch with Kristina or myself, and we'll make sure that you have all that contact information. The one other thing I did want to touch on, and that was back, I was trying to find where it was, is depression and anxiety, and how that works into some of these diagnoses, and you know, is like, what comes first? Is it the arthritis? Is it that makes you depressed? Or is it depression that triggers some of these conditions?
It's impossible to know. People who live in chronic pain will develop depression, right? It's hard for you to wake up and go to sleep with chronic pain. But sometimes we know that, particularly in the case of fibromyalgia, sometimes depression comes in before the pain. Depression causes pain, right? People feel more tender. They have a lot more pain than regular, like people with no depression.
Right.
We know that, but it's impossible to know, because like I have lupus patients that also, just for having a chronic disease, can develop depression and anxiety, because you don't know what your day is going to be tomorrow. Today is a great day. Tomorrow you may be in bed, and tomorrow you may be in the hospital, whatever it is, right? So this kind of like on and off kind of roller coaster day for anybody with an autoimmune disease can be enough to cause depression and anxiety. But as you said, I can't tell what came first. We have to treat both. That's the point.
Right. That's great.
Depression gets better, right? Because you treated the cause of the depression, and sometimes not, and then you have to treat both.
Right.
Would that be coordinated, like for mental health part as well with the, you know?
We try, but mental health lately, since the COVID pandemic, is almost impossible to get a referral. And sometimes I will call and they say, hey, just send them to the hospital, and then they're admitted, and then they're assigned a psychiatrist. Like, that has to be a better way. So it depends on the insurance of the person. It depends on, you know, how fast do you need to see. So mental health referral right now are very, very, very difficult to get anybody very quickly. Sometimes you had to call mobile crisis to get them assigned. It's not just like, oh, call this number and you get assigned a psychiatrist anymore. Since the pandemic, things have shifted and is a lot more difficult. But the optimal way is to have all the teams at the same time working together so the person can feel better in every aspect, right? We're not just joints, we're not just autoimmune, we're a whole person, and we have to look at it when we're treating anybody.
Which I think you well know is not easy to get a medical team working together in this day and age, when the medical individual people are pressured for all kinds of other things. Performance, whatever.
But yeah, we are very much pressure right now.
All the more why the patient has to have support, and or the patient themselves have to help manage this whole thing.
I usually give a lecture where I teach patients how to talk because you basically have 10 minutes with your provider.
We actually, I'm so sorry, we have to go to a break. I want to thank you so much, Monica. Like I said before, it's been a wealth of information. We're so grateful for having this hour with you. And I know that Kristina will definitely have you back, maybe talking in person to our seniors. But again, thank you so much. You're listening to Project Independence, a new community talk radio on 88.1 FM and WCWP.org.